Our Needle Exchange is only been a couple of years, right?
I think longer than that.
There's a market.
Good evening. This evening, the date this evening is Monday, May 13th, 2024, and it's 5:30 PM. Call to order. We're going to start with a presentation for the city update from Mr. Brian McCain, Chief of Staff.
Thank you, ma'am. Few updates this evening. Currently, we're accepting applications for the following boards and commissions. The Housing Authority of the City of Pueblo Board of Directors with a deadline of May 20th. One appointment available to serve a 5-year term. One appointment available for public housing resident to complete a 5-year term. The Pueblo Conservancy District with a deadline of May 20th also. One joint appointment available to serve a 5-year term. And the Board of Health with a deadline of May 28th. One appointment available for a city resident to serve a 5-year term. May 17th from 9 to 10 a.m. at the Mineral Palace Greenhouse. The city presents the Parks Project, Inclusion Garden Planting, where people can come over and plant in the community garden. Team Up to Clean Up, Saturday, May 18th from 8 to 3 p.m. at CSU Pueblo Thunderbolt parking lot and Colorado State Fairgrounds through the Mesa Avenue entrance. Black Hills Energy will have energy efficient kits for free, household waste only, and it's free for city residents. No electronics, no commercial waste, no hazardous materials, no rocks, concrete, or cement accepted. Also that Saturday, there will be a used motor oil recycling event from 10 a.m. to 1:30. Open to Pueblo residents free of charge at the Pueblo Recycle Works facility on Stockyard Road. Residents may bring up to 5 gallons of used oil for recycling. No contaminated oil, which means oil with water, dirt, or other substances, will be accepted. The city will return and residents will be required to keep the container that the oil was brought in. The dog park has reopened after the reseed. The grassy area is reopened after spring seeding. Thank you for your patience. Northern Avenue paving project. The first phase of paving work began today on Northern Avenue between Prairie Avenue and Abriendo Avenue and will continue through May 23rd. During this first phase, the westbound lanes of Northern Avenue will be milled and paved. The second phase to mill and pave the eastbound lanes will begin on June 3rd and continue through June 12th. Pueblo transit stops will be affected intermittently during the project and riders may need to board or exit buses at alternate stops. We ask that drivers remain vigilant and exercise extreme caution in the work zones. And City Park opening weekend is May 25th through May 27th. And the City Park pool 12 p.m. to 2:30 p.m. and 3 to 5:30 p.m. And the rides at City Park from 5 to 9. And that concludes my report.
Great, thank you. Clyde, some of our screens are going blank. Can we get that looked at before we proceed? Tonight's the night. We'll continue with the meeting. Any questions for Mr. McCain or the mayor? From council? None this evening? Okay, well, we'll move into our first, oh, did you have more? I'm sorry. Okay.
No, that was it.
We'll move into our first guest tonight, and that's Sarah Money and Christine Chiron with Access Point Pueblo.
And we had submitted a third person, so yeah, this is Tori Serby, but we'll introduce ourselves fully when we get started. Are we good to wait till the slides are back up, or shall we start now?
Okay, go ahead and start, ladies.
All right. Well, hi, we're Access Point Pueblo, and we operate one of the 2 syringe access programs here in Pueblo. We operate out of District 2. My name is Christine Chiron, and I am a certified community rehabilitation provider and 5th generation Puebloan. I live in District 3, and I'm the prevention services manager overseeing our harm reduction and sexual health programs.
And thank you for having us today, Council. My name is Sarah Money, and I'm also working. Is it on? Yeah. Okay, I'm currently working on my doctorate of public health. I moved to Pueblo 4 years ago and have been a resident in District 1 since I moved here. And so the way that I continue to serve our community is as the Health Hub Program Manager at Access Point.
My name is Tori Serby. I'm an LCSW and licensed addiction counselor candidate. I live in District 3. I was born and raised here in Pueblo and received my undergraduate and graduate degrees in Northern Colorado. Establishing my career in community work, I decided to do that back in my community and where I came from, and I am our behavioral health manager.
And so
I'll just wait on that. But if you want to keep going, Sarah.
So to give us an overview of what we are going to cover in our presentation today, first, our goal for our presentation is twofold: to highlight the breadth and depth of our work and to respond to concerns raised by the community and city councilors with data and transparency. We will touch on our history, provide an overview of our program, and discuss the concerns raised by council and how programmatic data relates. We will end our presentation by stating our commitments to the community to actively address the issues that bring us all here tonight.
So just real quick, I want to give a brief overview of our organization. So our agency is Colorado Health Network. And for the past 40 years, we've been responding to public health crises throughout Colorado. From the beginning at the forefront of HIV/AIDS in 1983, when our work began, to pivoting to evidence-based solutions and responses to the opioid crisis when we opened our doors at Access Point here in Pueblo in 2014.
Access Point, our syringe access program, serves as the entry point for a well-rounded suite of services we continue to build for the community under an integrated care model. What we have here is a graphic that kind of illustrates what we offer in-house as well as throughout the community. So those white bubbles are our in-house services. So alongside Access Point, we have mental health, dental, infectious disease, and testing services. The gray illustrates our on-site community partners that provide wound care, hepatitis C, and STI treatment. The blue is our network of regional providers who provide medication-assisted treatment, primary care, and recovery services. And then in yellow, we have our peer specialist, which we offer in-house as well as have a network of peer community as well. We would not be able to link people to these critical health and wellness interventions without operation of our syringe access program and the continued support that staff daily provides to our participants. Within that integrated care model, we also have our behavioral health program, which we launched called Connection Point. It is a low barrier mental health drop-in program for Access Point participants. For anyone here who has sought mental health care for themselves or loved ones, you know how difficult accessing care can be. Providing access to mental health professionals without the hoops of intake assessments, appointment setting, and more allows for participants to rebuild trust in providers. We often hear the root cause of many of our social ills, such as drug use, would be better solved by access to mental health care. And that is exactly what Connection Point establishes to do. With our integration with Access Point, we have established that every participant has an opportunity to meet with a therapist during our program times. Our Connection Point program in Pueblo has been so successful. In just 4 short months, our model is being adopted statewide across Colorado Health Network locations. Our success is illustrated by the 289 participants who engaged with one of our therapists between January and March of 2024. As we anticipated, this low barrier access to mental health care has prompted 39 individuals to engage with a higher level of care and 24 to return for continued counseling services.
So beyond providing comprehensive tools and supports for our participants, Access Point has also had a long history of providing public health and safety education for the community. So first, since the beginning of our operation in 2014 as Syringe Access Program, we've prioritized the health and safety of our first responders and our law enforcement officers by ensuring that each and every participant that comes through our program is notified on the needle stick prevention law here in Colorado and the recommended practices alongside it. Without syringe distribution, the participants who need this education the most will be less likely to receive it, putting our law enforcement and first responders at risk of accidental sticks. Other services and education we provide to the community at no cost to the city or county include HIV, hepatitis C, and sexually transmitted infection testing and linkage to treatment. We've also integrated this into our syringe access program, so participants who are picking up supplies, engaging in behavioral health or anything else can access that service. We also provide overdose prevention response training to anyone in the community, not just our participants. And finally, we provide education to anyone on safe pickup of sharps, containment, and disposal, including free disposal with us.
And so over the next few slides, we have heard your calls loud and clear, wanting to hear local data on harm reduction and on the efficacy of syringe service programs. And so, one of the common questions, how do we know that they're effective? Well, I want to go back to kind of the root of harm reduction, which is HIV prevention, and discuss local HIV data to demonstrate just one of those measures of efficacy of syringe access programs. And so the bar chart that you see on the left demonstrates HIV diagnoses in Pueblo County, which are tracked by CDPHE, the state health department. The teal represents new HIV infections that are not associated with injection drug use. The purple represents HIV infections that are associated with injection drug use. And so our program opened in 2014. And what you can see on these slides is that in the 9 years before our program opened, injection drug use was responsible for 21.9% of the HIV infections in Pueblo County. Since we have opened, the 9 years following, injection drug use has only been responsible for 13% of HIV infections in Pueblo County. And so we highlight this to demonstrate that this is directly related to us providing supplies and education to people who use drugs, as well as early intervention services and case management for people living with HIV, which is another critical part of the services that we provide.
And then for any of us who aren't as much chart people, we also want to bring to light the idea that infectious disease knows no boundaries. So as you can see on the right side, this is just a small snapshot of our state with the county maps. Crowley County is highlighted in red because it has been identified by the CDC as one of 200 counties in the United States as being at risk for an HIV outbreak. Now, we're right next to them. And so what we also want to bring light is the fact that disease outbreaks and HIV outbreaks through injection drug use isn't just something from the 80s and 90s either. We want to highlight the case study of Scott County, Indiana, which was in 2015. And in that case, sorry guys, let me find my spot here. So in Scott County in 2015, which is a much smaller community than us, over an estimated 181 people contracted the disease or infection of HIV through injection drug use. And this was an unprecedented outbreak in HIV for that area and for that size. And we know that that was costing an estimated, or continues to cost an estimated $2.4 million annually for that state to be providing for those individuals who contracted the infection through the sharing of drug use equipment. And so the situation was so dire that then Governor Mike Pence implemented syringe access services to suppress the crisis. The removal of syringe access services in Pueblo could result in southeastern Colorado being the next case study for the CDC. I have the clicker. Okay, in continuing with local data, we also wanted to touch on some efficacy behind our program being great at responding to the opioid crisis. So one hallmark of our syringe access program is overdose prevention and response training. And one thing that we do is distribute naloxone to our participants, and they have been the most effective at responding to opioid overdose in our community. So if you look at this graph up here, what you can see is in the purple, the number of overdose reversals that were reported to us by our program participants. So this was individuals responding to overdose in our community with the naloxone provided by us and SCARA, and then reporting the lives saved back to us with that community naloxone. You can see that between 2020 and 2022, which was the height of the opioid and fentanyl crisis, you can see that overdoses and overdose reversals by our participants more than doubled between 2020 and 2022. You can also see, though, that in the dark blue, as we went through those years, the overdose fatalities here in Pueblo stayed level, even dropping in 2021. And so what we know is that this proves and shows and illustrates that our program provides this type of intervention that not only saves money, but saves lives.
And we truly fear for the future of Puebloans with diminished access to this cost-effective, life-saving tool. As many in this room intimately know, opioid overdose has become one of the leading causes of preventable injury-related death for American adults. Substance use does not discriminate, and our participant population cuts through lifestyle, economic situation, and more. Many of our participants are even parents. In a recent study, an estimated 321,566 parents of children in the United States lost their lives to a fatal overdose over a 10-year period. While we recognize some do not agree with the provision of sterile supplies and harm reduction education, we want to be very clear that substance use touches everyone, not just people who inject drugs. Our life-saving evidence-based methods open doors to recovery while people are at the darkest points in their lives, and we know that people do recover. And so in response to community concerns about syringe disposal and litter, we want to be very transparent and discuss the ways syringes are being disposed of in our community, as well as opportunities to improve syringe disposal. This pie chart represents 9 months of syringe distribution from our program and 9 months of syringe data that is syringes that are returned or disposed of across Pueblo. And so we track syringes that we distribute and syringes that we collect directly. In the blue on the right, you can see that 39.2% of the syringes that we distributed were exchanged back to us directly at our program, Access Point Pueblo. At the bottom of the chart in turquoise, you can see that 16.6% of syringes that we distributed were disposed of in one of 2 kiosks that are located in Pueblo. These are kiosks that we spearheaded and that we regularly monitor for disposal. In order to get this next number, we actually did a survey with our participants about the ways that they dispose of syringes. In dark teal, you can see that 23.3% report disposing of syringes in a CDPHE and CDC approved format. And the responses from participants were honest and do align with the return rates that we see. And so we do have confidence that many of our participants were being honest about this. And then finally, you can see there is a yellow category that means we cannot account for 20.9% of the syringes that we distribute. But I do want to point out that that does not necessarily mean they end up on the street. And you can see other factors that are involved here on the slides where, there are many, many people who only came to our program once, meaning they didn't have the opportunity to return syringes. There are people that are experiencing paraphernalia seizures. Those are syringes that we're not counting. There are people that are trying to dispose of them, but maybe aren't sure of the right way to do it. There are also people disposing at other harm reduction programs and disposing at places outside of Pueblo. Looking back at this 20.9% gap in proper disposal, what we also want to point out is that a worldwide meta-analysis found an average return rate of 90% at syringe service programs. And so we're about 10% away from the worldwide average, and that is an opportunity that we have. Without us here to educate and provide that safe disposal for our community, we would see much higher rates of syringe litter and stand no chance at improving returns. People will continue to use syringes, and we will lose that missed opportunity for improvement and increased community safety.
And so to dive in a little bit more to the syringe litter issue, since it does seem to be maybe what brought the ordinance here to the council, we do want to discuss a little bit more about some of the activities that we have done in order to try to mitigate this issue. And these are things we've done over the years. So for years, we have worked closely with Pueblo Police Department to respond to calls made to dispatch. Dispatch routinely routes those calls to us, and we respond and pick up those sharps within the community. We recently did this as well for code enforcement and regularly receive syringes from Parks and Recreation staff to dispose of freely at our location. We did have some funding in 2021 from the city through ARPA, but for now and since then, we do this all at no cost to the city or council. We also want to highlight some other efforts we do. Besides providing that to the city government, we also do regular cleanups as staff and volunteers. We outreach to businesses for safe disposal, providing sharps containers, PPE, and more. And we assist any people in Pueblo with applying to the CDPHE funded kiosks you'll find at our location and at the Ethos in Bessemer. Those are completely free for maintenance, by the way, so no cost to the property owner. Most impactful, though, on syringe litter, as Sarah pointed out, Access Point and SCARA are the two main entities that provide direct education on safe disposal, providing sharps containers, free accessible disposal, and that really important needle stick prevention law education. With an end to needle exchange programs in Pueblo, we're certain our ability to provide this to the people who need it the most will be greatly diminished.
We have heard the concerns voiced by council members, and we are here today to avow our commitments to being part of the solutions to the issues that have been raised. One, we aim to reinvigorate collaborative efforts to address syringe litter. Two, ensure additional care and treatment information is provided at each visit by labeling our distribution bags. Three, we want to work with the city, local health department, and Board of Health in the spirit of transparency to undertake regular communication regarding our services. And we want to reaffirm our commitment to continue responding in collaboration to infectious disease throughout Pueblo and our region, continuing provision of free and effective overdose prevention and response training to the entire community, ongoing cultivation and referral networks for care and treatment. And finally, we are committed to continuing our role as content experts on emerging trends that may threaten our community.
And we're just about finished, so thank you. But we've provided a lot of data and evidence today, but we also really want to leave council in the community with words from members of our community whose voices have been left out of this conversation. And so I'm going to be reading a quote that one of our program participants provided to us here in these last few weeks. The Access Point Pueblo program is more than just a needle exchange program. They have made access to medical and dental care more readily available. Personally, they have taught me a lot as far as the need for proper disposal and storage of needles. I've honestly gotten to the point in my life where I am personally seeking out treatment on my own to get clean after using meth for 6 years and injecting for 4 of those years. The staff at Access Point is the reason behind that. Beyond just providing access to supplies and medical care, they provide an empathetic, understanding atmosphere that made someone as standoffish and antisocial as myself comfortable talking to someone about my struggles with addiction and being 100% honest about it. That, in turn, allowed me to be 100% honest with myself about my addiction. I have always heard the phrase, you can't make someone quit until they are ready to quit, and you can't be ready to quit until you are honest with yourself about your addiction. So thanks to Access Point Pueblo's patience, understanding, and compassionate support, I, after 6 years, am ready to quit meth. Thank you. And
And we have just one final slide with our ask for you all. We know we're over time, but we hope you'll be okay. We know that you all care a lot about the city of Pueblo and our community here. And so we did pull this quote from your website that we happened upon, that without a sense of caring, there can be no sense of community. So our ask to you all tonight is to pause the vote on this ordinance so that we can collaborate on real solutions that will have real positive impacts for all members of our Pueblo community. Thank you.
Okay, we have a long evening this evening. Let's try to keep our clapping to a minimum. We're allowing it, but it's not a normal, it's not how we normally work with a work session, okay? So let's just mutual respect. We want to move through this evening. Do any questions from council? Councilor Martinez.
Yeah, thank you. I really appreciated seeing the data. So I want to acknowledge that, and just your voices coming to the table with this tremendously important topic. So I do have a couple of questions. My first question is, how many grant funds does Access Point bring to the Pueblo community?
So we do share some of our grants statewide, so I don't have the exact number off the top of my head, but most recently when I was doing a survey within the last couple of months for our syringe access program, the estimate was about $250,000 for the Access Point Pueblo program. And that's only our syringe access program, not our other prevention programs.
And your budget for Access Point is primarily based off of grant funding, I'm sure private foundations, and then state and federal, no local dollars are going into that.
We have no current local grants. All of our grants are statewide here in Pueblo at the moment.
And how many employees do you have at Access Point?
That's a tricky question with our integrated care model. For me, I have 4 employees under me in the syringe access program and myself, so that's 5. And then we also have 2 behavioral health staff that are fully integrated and 3 health hub staff that are fully integrated as well. So I think that puts us at 10 or 11? 10.
10. So 10 employees who have full-time jobs are on the line if should Access Point be closed. Plus $250,000 that's brought into Pueblo, plus more, I'm sure, with the revenue that's collected at Access Point. That's a lot of money and a lot of jobs. For the disposal piece, and I know that I've been walking my district, and whenever I see needles, I usually give you guys a call, and then you come out in X amount of time frame and you'll pick it up. How much does the disposal cost in terms of actually sending FTE to go dispose and then actually disposing of those needles?
That's definitely where it's tricky for us to know. The disposal is paid for by the state of Colorado within our big, large statewide contract. So it's not something that we're able to have parsed out for Pueblo itself tonight, but that is something we can see about getting from our medical waste company and or from CDPHE.
Yeah, that I guess I'm curious in that number, especially when we're talking about like who would be picking up the needles should Access Point close. What's how much money does that cost? Like, what's the fiscal impact on that?
Yeah, we can definitely look into that.
And then for the kiosks, I understand that those are also grant funded. How much does it cost to operate or get one of those kiosks?
So I can actually speak to the kiosk portion. Both of the kiosks that are here in Pueblo came at no cost to us or to the city of Pueblo. They are both funded through the Colorado Department of Public Health and Environment. Now, what I will say is that is a somewhat limited opportunity, but in recent conversations that I've had with that department, I know that Pueblo is a priority as far as trying to get more kiosks located here. It's more of a matter of our people, our companies, our businesses willing to actually be a host site for that kiosk, but they do come at no cost to the city, and the state even covers disposal fees for those kiosks.
So they maintain those on top of that.
Yes, they do.
Okay. Thank you.
Madam Chair,
Counselor Latino.
thank you. As I understand it, 31% of the needles are returned. Is that correct? The used needles, is that correct?
39.1.
39.1. So that means that 60.1% of the needles are not returned.
No, sir, they are returned to other places. So they're
Like where?
returned to the kiosks, or they are safely disposed of in the manner that CDPHE, our state health department, and the CDC recommends if folks are unable to make it to one of the 2 locations that has those kiosks.
So why do we have to sweep the elementary school on the east side called Bradford Elementary every single morning and every single afternoon because there are used needles on the campus where children are? And we had a child, a young woman, a little girl stabbed with a needle. Tell me about that. It is proved.
May I answer, sir?
Answer.
So what I would say respectfully is that's an opportunity that we have to provide better education, as well as an opportunity to increase safe syringe disposal options in that neighborhood. And we recognize that the east side has been hit hard by substance use. We have also heard feedback from many residents on the east side that they would appreciate a kiosk and that a kiosk would help reduce that. And so I am not here to say that that is not a horrible situation. I'm here to say that there are ways that we can address it, and that communities that have shut down programs see worse issues with syringes around. And so with what we are asking for today, we'd appreciate the opportunity to work to address that and reduce syringe litter, particularly in the east side and in the ways that it impacts our youth in our community.
We have the principal from Bradford Elementary School here. I think she's here. Michelle, are you here? Michelle Padilla.
Excuse me, we're not asking you. Mr. Latino has the floor. Thank you.
Again, it's going to be hard. You're going to be hard pressed to change my mind. I spent 35 years in education in the metropolitan area of Denver, and I was raised on the east side. I have a family member who was a bureau chief for all undercover operations for the entire FBI who was from Pueblo. Okay?
Councilman Latino, we are very eager to be collaborative in this approach to address your concerns. So I truly want you to understand that we are absolutely here to support the community, to hear from the people who are eager to find solutions to safe disposal, and give us a call and we will come get it.
I can't be calling everybody. Okay? I get enough calls every day. I'm responsible for this community and not only my district, but this entire community. And when we're picking up needles and I have children being affected by this, I got to tell you something. And I'm going to be very candid about it right now. When we make a vote, I want needles out of Pueblo.
Okay, thank you, Mr. Latino. Counselor Flores.
It's strange to me that both you and Southern Colorado Harm Reduction, I guess, blame it. Really, if you look at the commentary throughout the city the last couple of weeks, it's almost like they're looking at the two of your organizations as being the cause of disposed needles. And that's really a shame because if we were to remove both you and Southern Colorado as a result in the picture of removing needles, I'm wondering if you have a percentage of, Pueblo's a pretty large place. Pueblo County's, 170, we're at 120. Have you ever thought about what impact you have and how much of the blame you really should be given? I guess although I don't believe there should be any blame, we should be thankful that your organization is willing to do this. But if you were to tell me that you and Southern Colorado Harm maybe represent 10% of the problem, I would probably believe it, because the problem is much bigger than your two organizations, and at least you're trying, to minimize, the exposure out there. I don't think anyone has brought an alternative to this. Everyone seems to want to suffocate what you two are doing, but there's no other alternative. The kiosk is a possibility, but I think I heard you say you only have 2, and maybe the solution is to have more in the community. But, anyway, I'm going to stop there because I think, there's a lot more questions that I have, and obviously, that we'll be dealing with that. There's a legal aspect to this. There's a Colorado state statute, which we and the state of Minnesota are the only 2 that have, so that we need to dig into this deeper. And so I'll do that at another time. But I think we need to put in perspective. It's easy for us to look at you and blame you for, I guess, all the opioid problems in the community. At least you're trying, and I appreciate that.
Counselor Aliff.
Yeah, thank you. Very good presentation. You gave a lot of good information there. I guess I just want to clarify a couple things. So you have a very diverse operation. I went over there. We went through it and everything. And the needle part of it is just one small part of the entire operation. I understand that it's the gateway, that how you reach people, a lot of the people that you deal with. I'm sure it's not all of the people. So my question being is that if next week you could not give out needles, you'd close?
We wouldn't close because we're committed to being here for our public, for the community at large, to keep providing what we're able to provide through our funded services. So I don't believe we would close if this ordinance were to pass and go into effect. But I do know that our ability to serve and meet the needs of this population, which has a lot of ripple effects, as we mentioned, with the death of parents, the death of loved ones, disease transmission increasing, increases in litter of syringes and whatnot. So no, we would not likely close, but it would severely impact our efficacy to bring solutions that are going to help the problems that you all are discussing here.
So literally you could still be the distribution point for the Narcan or the drug reversal. They could come in and still get that from your organization?
So the technical answer to that is yes. The realistic answer is, as Christine mentioned, many, if not most people that come to our services come for the syringes. And what I will say is that we know that next week, we will still be here doing what we are legally allowed to do, but this will impact our funding long-term, and it will impact the risk of infectious disease long-term here in Pueblo County and across the Southeast.
I understand that. In 2023, how many syringes did you distribute?
We don't have that number pulled for you this evening, but if we can continue the conversation after tonight, we'd love to prepare that for you.
See, I've had these conversations many times over the past 6 years of, this is the part that really concerns me, is every time we ask, well, how many, we have numbers of how many come back, but we don't have numbers on how many were put out there. So how do you know that only 20.9% are still out in, maybe not the community, but just weren't given back? That's
No, I
Kind of
completely
crazy.
understand that. So as we were pulling the data for slide number 9, which is the pie chart specifically about syringe disposal, we chose to look at just the last 9 months. And so what I can tell you is that we did dispense 345,000 syringes over the past 9 months. The unaccounted for amount is about 72,000, but 62,000 were given to people that left Pueblo and never came back to our program. And so we do absolutely have the numbers. I think we were just unsure kind of which time frame that you wanted to hear them from, but we are more than happy to provide data all the way back to the inception of our program in 2014, because we do have the annual data for that. And so I apologize, but we absolutely have the data and are happy to provide that, just as long as we know kind of what time frame you're looking for.
And then the last thing I want to talk about is the part of the presentation was on HIV, and that it had gone down, that only 13% was a result of injections. You know, because it's very, I know this is a big deal and that we all need to have all the information. I went through our local health department through Mr. Evans, who's the director, did a request and got all of the information on Pueblo County HIV and hepatitis C. And I just took between 2005 and 2013, the average HIV infection per year was 7.11. That's just 7 infections per year. From 2014 to 2022, it jumped to 10.22. Not to mention that 22 and 21 were absolutely the highest. So we keep getting this argument of we need to follow the science, we need to understand what we're reading, we need to look into this, don't make a decision from the seat of your pants. So I delve into it and I try and get the information so I know that I'm getting good information. And one thing that's always concerned me in the presentations is that we want to tell you about a study that was done in Wayne, Indiana. We want to tell you about a study that was done in Miami, Florida, but there's never been a study done in Pueblo, Colorado. And nobody ever uses the numbers from Pueblo, Colorado. It's simple to say that 13% there's a reduction in actual use, but that's self-reported under my understanding, correct? I mean, if I get HIV, how do they know that I'm a drug user?
That's not self-reported. That was from CDPHER numbers. So from the
But
state
how
health
do they
department.
know
And
that they're,
we work closely with their disease intervention specialists who do a lot of follow-up with the individuals, where they're able to get all of that information through interviews with each of those individual cases.
but you can understand my point of view that if I look at the data shows when we started with this access programs in 2014, we've steadily risen in the amount of HIV within the community. Is that fair? Or am I wrong?
You are not wrong. But what you are seeing is what many places in America are seeing, where HIV rates overall are increasing. And so in doing the data as we were preparing this bar chart, which I'm an epidemiologist, so I take a lot of pride in making sure that our data are accurate. But we would have had approximately 8 more cases of HIV in Pueblo County if the rate of infection or if the rate of HIV associated with injection drug use continued in the way that it was trending. And so the numbers are still increasing. And what we wanted to really represent, and maybe didn't express ourselves very clearly, is that they would be increasing much faster if we were not here to specifically help people who are using drugs reduce HIV. And another factor that we can throw out there is that, we are working hard with other populations to reduce HIV risk, not strictly people who inject drugs. And so we're trying to work on that whole bar. But what we would have seen is much higher rates of HIV had we not been here working with people who were using drugs. Does that answer your question?
Yeah, it's speculative. So, because we don't have the data that shows us that if you weren't here, that it was going to be, because when you weren't here, it was lower. You did come here and now it's higher. And if you look at hepatitis C, it's the same scenario where we go from 137 a year prior to these access programs to now we're at 156. So there's an increase. And then the numbers are skewed from 2020 to 2023 because of the reporting and COVID and all that other stuff. But once again, I'm not trying to be combative or anything. I'm just saying that I get this information and it contradicts everything that is said to us and to me specifically when I get the emails and we hear the testimony and the conversations, that without this, it's going to be mayhem. But the data doesn't support that.
So I'm not sure if we made it abundantly clear that, we're through our syringe access program, which is what we're trying to discuss here tonight, and as it relates to the infectious disease rates. When we started our syringe access program in 2014, if we were to only look at the graph and the HIV rates as they relate to people who inject drugs as the source of that transmission, we have decreased. So we have been successful in curbing the amount of HIV transmissions happening in our community via injection drug use amidst an opioid epidemic and crisis. So if you look across, and we can't give you the exact numbers, unfortunately, that you're looking for because we're operating in the midst of an epidemiological crisis. So that's why we're seeing increased rates of hepatitis C. I know when I came here in 2021 to present to the council, I referenced that in 2020, we saw a 35% increase in the amount of participants at our program. So we know, in fact, that there's just been an increase overall across our community and the country with using drugs and injecting drugs. And so while, yes, HIV has increased across the board, we're a small operation trying to do our best here to try to mitigate that, but we aren't the only answer either. And that's why we're here asking you to work with us to try to find those solutions that are going to work for the whole community.
Thank you.
Okay, any questions from any other counselors? We're running over, so.
Yeah, I can imagine how difficult it is to get good research material. Since I've been researching this thing, I found articles that state that over 10,000 medical and scientific decisions were reversed last year alone. So for you to have to depend on the medical community and the authorities that come forward, I can imagine what a nightmare it is. Are you familiar with the 3 other agencies that pick up needles in Pueblo?
Most likely, but if you can tell us, that'd be great.
Okay. I'll tell you, Parks and Rec just gave me a readout of 18,000 needles they picked up, and that's just from the parks in those areas there. I think the creeks. Then Public Works also has crews, and I'm not sure if they keep data. I couldn't find it. And then finally, the code enforcement folks as well. Do you actually have a team from Access team that has a schedule daily where they go out and pick up? No, that's not something you do.
No, it's not really something that we're funded for mainly, but I think what Mr. Latino had referenced about a little girl getting poked by a needle at an elementary school might have been from 2021. And that's actually when we came and presented. And so we have kind of revamped and started in 2021, putting a lot more focus on syringe cleanup and disposal. But since it's not a core service of our funding and contracts, it's not something that we have staff or time dedicated to. It's simply something that we've put as a priority to try to be responsible and responsive to our community since Sarah and I started managing the program.
Can I make a recommendation that you might want to take a look at? I mean, I've looked at infectious diseases, HIV and Hep C and all that stuff. And, you know, the guys I grew up with, Magic Johnson's been dealing with this for 32 years, for Christ's sakes. And a lot of the infectious disease are a lot more manageable and treatable today than they were back when. Before you guys came into Pueblo, who handled all this before you were here?
So we know for a fact through a majority of our participants, not a majority, sorry, let me rephrase that. We know from a lot of anecdotal conversations over the years with our thousands of participants that a lot of our individuals that have an infectious disease don't get it treated. So what we're really trying to do is work with the people that are the most marginalized and disenfranchised from the medical community to ensure that those individuals are getting adequate access to education and tools so that they're not then in turn spreading their chronic hepatitis C or spreading untreated HIV. And as we mentioned in our presentation, we also work in-house to provide hepatitis C treatment on a culturally competent way through 2 different providers that we work with remote. And those individuals, we've already had one person who is completely cleared of the infection with this novel partnership that we've started. And so that's really our aim. Unfortunately, we don't know exactly who was dealing with that in the past. I guess PCHC, they're still a big part of the picture.
I just make one more thing and recommend that you take a look at, I think you've done a good job in reference to harm reduction, in reference to infectious diseases. I think the last stat, again, I hate to use them, 3 to 5 cases in reference to infectious contracting an infection as opposed to dying from an overdose is much greater on the overdose end of it. So why can't they change the mission from habit reduction, from harm reduction to habit reduction and focus in on that? Because that is 118,000 deaths last year in the United States alone. So why can't we do that?
That, sir, is our goal, especially in integrating. This is a really cool thing that we've been able to do here and have received funding for in response to the opiate crisis, is to have mental health professionals available at Access Point for participants. We engage with everyone who walks through the door who's wanting to talk to a mental health professional to start having those conversations. Everyone has been trained in motivational interviewing to ensure that people who are ready to go and access treatment have the support that they need. And we just started in January. So we saw 329, sorry, I lost the number.
289.
Thank you.
Well,
Individuals.
And beyond the behavioral health lens, even prior to that program, we've always provided habit reduction counseling to individuals. So a really big part of our program, and we'd love for all of you to come and be able to meet our staff and discuss this with them, is providing that very kind of no judgment, low judgment space where people can come to us and talk about, hey, I'm really sick of this. I don't want to do this anymore. And we're able to have those conversations again and again with them over the course of months, sometimes even years, until they're ready and in a stable place where they can actually access those services and be successful. But what we know, and what any of you likely know if you've experienced addiction or have loved ones, is that it takes a long time for someone to have successful recovery. You know, it takes a lot of trial and error. It takes a lot of relapse in some cases. And what we really want to do is be here to help counsel people and keep them as safe as possible and really help kind of usher them in to whatever services, whether that be treatment and recovery, whether that be preventative, you know, regular primary care, whether it's behavioral health, or in a lot of cases with our integrated care model, we're hoping it will be all of it, including dental.
Counselor Hernandez.
Thank you, Madam Chair. I applaud you on the quality and competence of your presentation, sincerely. Comment you made when you were responding to Counselor Aliff regarding that if the vote is yes to eliminate the needle exchange programs within Pueblo, what you mentioned was there'll be a ripple effect. And the thing about, and I'm applauding you for, here again, the quality and the competence of your presentation and what I'm hearing from you and looking into your eyes and the passion in what you do. The thing about people and humans are incredibly adaptive. And a philosophy and a perspective I have with my experiences is that with challenges comes change, right? With change comes opportunity. We may not like the opportunities that were presented or taken away. But with that is adaptability to find new pathways. Okay. So it's more just a statement and an observation. Thank you.
I have one more.
All right. Come on,
I support what Councilman Hernandez has said. It was very, you coming here and presenting what you presented is not easy. I respect you. Young people mean the world to me, okay? I respect you. Obviously, you know where I am as it relates to this. I have a great concern for this community that I was raised in and came back to. And young people mean the world to me. So I applaud you. I thank you for listening to what I had to say and others. And again, thank you.
All I have to say is I think from a perspective from the community, you all are known as a needle exchange, you in Southern Colorado Health Harm Reduction. What I'm seeing here though is you're not exchanging the needles. You're not giving them and taking a fair exchange because you have kiosks. You're putting it in to the responsibility of the user to make it to one of your kiosks. And in those kiosks, those aren't accurate counts that come from Access Point. They could be from SCARA. Why couldn't SCARA users go and throw their needles in there? So I think the community expected you when they started this program was for you, the clients to come in, you would hand them 10 needles and they would hand you 10 needles back. And that's where the trust is broken, because that's how the community was sold that the needle exchange program was going to take place. And so if you're not if you're handing out needles and not receiving the amount that you're handing out back, then that goes against what the community believed was going to be taking place with this. So then we now have littering and we have needles all over, and we have business owners, teachers, and all of them coming and cleaning up the mess that's created by the user who isn't responsible enough to dispose of their own needles. That's a huge responsibility to put on someone with an addiction, is to get high and then turn around and properly dispose of their needle. And so that's where we're here today. And that's why I'm seeing the needle exchanges being banned across the nation in all different sorts of communities, because the community, members of the community, the majority are tired of seeing needles and having to deal with used needles everywhere. And that's just what it boils down to. So, okay, well, we're going to move on to our next guest, and that will be the Apollo Project. We're having members from the Apollo Project, Dr. John Emahiser and Zan Kellogg. Okay. Welcome here this evening. If you please just state your names, introduce yourself, and give us let us know where you practice and a background of your expertise. Thank you.
Hello, my name is Dr. Alexandra Kellogg, and I'm a family medicine physician and resident physician educator here, both at Centura Health and, Common Spirit now, sorry, and Parkview Hospital. So I work at the two major healthcare facilities here in town. I have been working as a physician now for 5 years, and I've been working in addiction medicine and substance use disorder throughout that time. I studied medicine in Chicago at Midwestern University, completed my residency in rural Appalachia, where the opiate crisis hit. And then I practiced for a year on the coast of Oregon.
Hi, my name is Dr. Jonathan Emahiser. I'm a second-year family medicine resident here in Pueblo. I also practice at both the hospitals in town as well as wherever my residency decides to put me. I trained in Las Vegas at Toro Nevada School of Osteopathic Medicine. I have also been involved in homeless outreach and street medicine for more than a decade, having founded multiple nonprofit organizations to the ends of community health and supporting law enforcement.
We are here today to help share information on the importance of needle exchange programs, the life-saving nature of these programs, and the devastation that can occur where these programs are not available. And I know we talked a little bit about research, but unfortunately, as doctors, our whole job is evidence-based medicine, and we have to go by the research wherever it was done, because that's how all doctors practice. So we will be discussing research today. It is from all over the country, but that doesn't delegitimize it. It's still legitimate research. That's how it operates, and that's how medicine operates. So I do hope you will take it seriously, since that's our job. Also, this is more than a professional issue to me. It's affected more than just my work and more than just my patients. It has affected many of my friends, my family, in ways that have ended in both recovery, which is amazing, and death, which really sucks. Can I get a show of hands? Who here has been affected or knows someone who has been affected by substance use disorder? Leave your hand up if you know someone who has died of substance use disorder. As you can see, this disease is not an individual issue. This is a community issue and a nationwide issue, and it's something we need to band together to treat and help this disease and those suffering from it in scientifically proven ways.
All right. So many studies have been done trying to determine the best way to tackle intravenous drug use and the associated harm and diseases it inflicts on our society. Specifically in regards to syringe use, there are over 30 years of research that have been shown and continue to show that sterile syringe access is a vital part of modern public health. Highly regarded places of medical research and development, including the Mayo Clinic, the Centers for Disease Control, the VA, or the Veterans Health Administration, the United States Public Health Service, and the World Health Organization, all support the use of syringe exchange programs and are actively promoting their development and expansion. The Center for Disease Control, also known as the CDC, is the nation's leading science-based, data-driven service organization that protects the public's health. For healthcare providers, the CDC helps guide our practice by determining vaccination schedules for children, providing guidelines when an outbreak or a pandemic hits, and further developing and educating on preventative screenings and practices, just to mention a smidge of how it influences medical practice. The CDC is prestigious and well-trusted, and the CDC supports syringe exchange programs. And why? Well, we have a couple of handouts taken directly from the CDC website that explain some of the reasons. Do you mind if I come up and hand them out? Yeah.
So these are straight from the CDC website. This is information that is globally known, and a lot of other countries use the CDC as guidance in their own development of programs and such. So just a few points. Syringe programs are associated with a 50% decline in the risk of HIV transmission, which we saw here in our own place with injection drug use. Users of syringe exchange programs are 3 times more likely to stop injecting drugs, which is awesome. And most importantly, when 2 similar cities were compared, the one with a syringe exchange program had 86% fewer syringes in places like parks and sidewalks. A couple other data points. They also help with reducing Hep C by 50%, which currently Pueblo has some of the highest rates in Colorado of hepatitis C. They are also helpful in protecting first responders, including myself, healthcare workers, from transmission of disease through accidental needle sticks, which is something I actually have experienced in my job. They also found in 2015 that the more syringes distributed per the number of people who inject drugs in a geographic region, the more likely the people who inject drugs were to dispose of used syringes safely.
So overall, very good points with years of research backing these claims. But the fact of the importance and efficacy of syringe exchange programs doesn't just come from the CDC. from a study by Hagen et al. From the Journal of Substance Abuse Treatment in their paper entitled Reduced Injection Frequency and Increased Entry and Retention in Drug Treatment Associated with Needle Exchange Participation in Seattle Drug Injectors. They really like long study names for some reason. They found that new users of syringe exchange programs were 5 more times more likely to enter treatment than people who never use syringe exchange programs. So 5 times more likely to get into treatment if they're using the program. And that needle exchange users were more likely to stop injection drug use altogether. In this study, they concluded the findings of this study showed reduction and cessation of drug use and increased drug treatment utilization associated with needle exchange, and would support those of previous research. A recent survey of U.S. needle exchange programs showed that legal programs are more capable of drug treatment recruitment than are exchange programs considered to be illegal. Thus, restriction on needle exchange programs based on the belief that the programs will encourage drug use by sending the wrong message could forfeit an opportunity for reducing drug use in the community. Sterile syringe access doesn't only decrease drug use, though. As pointed out by the information from the CDC, syringe exchange programs also importantly reduce blood-transmitted infectious diseases and therefore greatly improve public health. According to the 2021 Public County Community Health Assessment, our county currently has some of the highest rates in Colorado of new chronic hepatitis C cases. Between 2017 and 2019, the rates of chronic hepatitis C was an average of 29.9 people per 100,000 more in Pueblo than the rest of Colorado. If syringe exchanges are truly cutting this incidence in half, we will be at risk of having hepatitis C rates over twice the average of the rest of Colorado. And hepatitis C is not the only disease that will also rise with the removal of syringe exchange programs. New HIV cases may increase by up to 200%. According to a study, higher syringe coverage is associated with lower odds of HIV risk and does not increase unsafe syringe disposal among syringe exchange program clients by Blumenthal et al. In a large sample of clients from 24 syringe exchange programs, we found that as syringe coverage percentage increased, the odds of syringe reuse and injection-related HIV risk decreased significantly. Other research reports that HIV transmission rates decreased by 50% thanks to exchange programs. In a time when our region is already battling a serious outbreak of syphilis, we must do all we can to prevent the rise of other fatal sexually transmitted diseases.
So, oops. I want to share some stories of patients I treated in areas where we didn't have exchange programs, because I have been on the other side of it. This is from my time living in Appalachia, where the opiate crisis hit very hard. And we weekly would have deaths from either overdose or syringe use, dirty needle use related diseases. It also meant that we did not have a lot of Narcan access. So names have also been changed because I have to be HIPAA compliant, just so everyone's aware. So Jake was a young man of 25 years old who I received as a patient after he was already brain dead. He had overdosed on fentanyl, and even though his heart was resuscitated, the oxygen depletion had left him without intact cerebral function. Though Jake appeared peaceful in his vegetative state, things were far from calm in the ICU. Imagine all the lights flashing, all the noises going on. Imagine entering a room with a forever comatose young man and a sobbing young woman at bedside. Imagine learning he had just used his Narcan on a friend who had overdosed a few days before and was going to go get it refilled later that week. And then imagine hearing that this young woman is 13 weeks pregnant with his child. Jake's body ended up being used to save lives. He was an organ donor, and that was the reason we had him alive in the ICU, though he had no function. But what did he leave behind? What was the cost? An orphan child? A widowed mother? Nurses and doctors fighting back tears? The toll on us as healthcare providers? All could have been prevented with easier access to Narcans and clean syringes. For most of my life, HIV was merely a horror story to me. It had killed many friends of my parents in the 80s, and for many years was known as the major public health crisis of our time. Thank you, COVID. But it wasn't until I cared for someone with fulminant AIDS that I truly understood the horrors of this disease. When I first met Greg, he was intubated due to AIDS-related opportunistic infection, devastating his lungs, unconscious from the brain inflammation caused by HIV, with skin rotting off in sheets from his 100-pound frame. He was the sickest person I was caring for in the ICU at the time, and this was during COVID. Thanks to God and my amazing team, Greg ended up recovering, but it took a 5-week ICU stay, multiple skin grafts, transplantation of his testes into his abdomen due to skin loss, a tracheostomy, which is a hole to breathe for you. And that was before he even got to leave the hospital. During his time in the ICU, I got to spend a lot of time with Greg. He actually remembered me when he got out. We would talk, well, mainly lip read. I would lip read what he was saying since he had the trach in. And during that time, I learned he had gotten AIDS from a supposed friend who did not disclose his HIV status and shared a dirty needle. According to Greg, his friend was on medication and thought he couldn't transmit the disease, so he shared. Dealing with severe depression and suicidal ideation from an abusive upbringing, Greg told me his only concern at the time was to try and escape his pain. Little did he know that 3 months later, he would be in the hospital fighting for his life just because he self-medicated without sterile equipment. Greg eventually did survive, but he will forever have the scars, colostomy bag, medication, and patchwork skin grafts for which he has a shared needle to thank. I share these stories not to overwhelm or depress you, but to remind you of the people that will suffer when syringes and the other resources provided are not available. Some of those people you may say are deserving because they are reaping the consequences of their own actions. But what about us who are innocent? What about the children orphaned by the loss due to an overdose? What about those who simply pick the wrong person to trust? What about healthcare workers who get a needle stick for caring for these people who are then affected with those diseases like HIV and Hep C? What about the trauma healthcare workers have to face daily and first responders, including our police force? These people were my patients several years ago, and I remember them vividly. Ask anyone who has seen the ravages of Hep C, of AIDS, anyone who has struggled in chaos to bring an overdose victim back to life, anyone who has walked through someone in their final moments of these diseases, anyone who has worked in healthcare, really, ask them and you will see how it affects us very deeply.
So this is where you all come in and help us understand your reasoning behind this ordinance and how you plan to help protect our community and its citizens if you decide to pass it. All of the research done in the past 30 years points to sterile syringe programs being the best option for reducing IV drug use, reducing HIV transmission, reducing hepatitis C rates, and helping drug users get into recovery. If there is a better option available, we would love to know it. What it is, as our goal as physicians and community members is just to reduce the number of people using drugs and improve the overall health of our city. If there is not a better option, then this ordinance should not pass.
If sterile syringe programs are banned, we would like to know, what is your plan to deal with increasing HIV rates in our city?
If it's passed, what is your plan to handle more people suffering and dying from hepatitis C in our community? Oh, wait, if
You're fine. If this ordinance is passed, what is your plan to support hospitals, healthcare workers, and first responders in caring for the increased number of overdose-related deaths?
And lastly,
Are you,
what is,
are you
what
almost
is your
finished?
plan
Because we need time for questions and answers.
We still have 20 seconds. Thank you.
Yep. So what is your plan to reduce the number of IV drug users? What was your plan to get them into rehab? What is your plan to replace that service that syringe access programs are providing for everyone in the city?
The reality is no one can recover alone. It takes a community of support to help someone on their journey. Do we want to be a community of heroes who help the
Okay.
despondent and those in need?
Your
Or do we
time is
want to
up,
dismiss those asking for
and
help?
that included your questions and answers. So, is there any quick questions from council? Councilor Flores?
Yes, I've gotten I don't know, volumes of information from the American Medical Association. And it appears that there's still that idea in our, in our communities that drug abuse and alcoholism are not diseases. The AMA differs with that. We definitely know that both, the abuse of drugs and alcoholism are truly both medical conditions. And I believe, I wanted you to comment on that because I think it's already definite science, and most physicians and medical professionals will tell you that those are diseases that have to be dealt with. And here we are talking about something that is not going to help these people. Could you comment on that?
Yeah, that's a great point. So an interesting fact is one of the medications we use for a lot of addiction and we use for, meth use or opiate use is the same we use for other addictions like tobacco use, like eating disorders, binge eating disorder. So we treat this exactly the same as we treat any other addiction, which is considered a disease. For example, with obesity, we will do bariatric surgery. We don't blink about it. And I'm glad we do. It has helped so many of my patients get to healthy weights and living lifestyles they like. But it's the exact same thing in the brain. The way the brain responds to it, it's the exact same with food, with tobacco, with opiates, with heroin, with, meth. So the way our bodies respond to these addictions are very similar. And that's why as medical practitioners, we look at them the same and they need the same approach of the right medication, the right resources, and the right support to get people back on their feet and healing from these addictions.
Yeah, if anybody's interested, you could go to the AMA website, which is ama.assn, which stands for association. And there are literally, I don't know how many articles, I got tired of reading them all, but it's pretty standard feeling within the medical community and the association that represents all medical doctors and hospitals that the needle exchange program does reduce infection. And that program is basically opens the door slightly for people to get treatment. Those statistics are in a lot of these AMA documents, and people should avail themselves of it and look, really do your homework because this to me is just a quick reaction. Obviously, nobody wants needles strewn everywhere, but you can say that about a lot of things that are strewn everywhere in this community, whether it's broken bottles, cans, you name it, that can also infect you if you're pricked by a broken glass that's been infected. So there's lots of data. I don't, it's the data that's driving me because in my soul, this is a medical issue.
And I would like to comment at the other part of my job being a faculty physician. I'm partly in charge of recruiting young physicians here to our community to train. Our work with the needle exchange programs is a huge selling point for incoming physicians. And, this council has spoken a lot about in getting younger, new people into this community. And this is something very important to the incoming resident physicians that we have in states where abortion was banned, for example. They have had a 6% decline in the residents who have applied for OB-GYN because physicians want to practice in places where evidence-based medicine is supported. And so in other ways, this is concerning for my job because I think it's going to be harder to recruit young doctors to this community if we don't have things like this that evidence supports.
Counselor Martinez.
So there was a comment earlier about how these infectious diseases are more treatable, like HIV, people are living for longer duration. Can you talk a little bit from a medical perspective, as you're the expert, about how, what's the rates of death with people who have HIV? What's the rates of death with people who have Hep C, and just how deadly they both are?
Well, I think it's important that we talk, we're comparing apples to apples and not apples to oranges, right? Because on the one hand, we're talking about if someone who doesn't have a substance use disorder they get HIV, right? They have better coping skills. They are able to get to their doctor's appointments. They're able to get into treatment. Then it's no longer a death sentence. But we're not talking about those people. We're talking about people who have, through circumstance and bad luck and, bad parenting, whatever you want to call it, they don't have the skills that we would like them to be able to get treated. And so the best way to keep those people healthy is prevention. We have to prevent them from getting sick as best we can. Because, realistically, the people that we see in the hospital with fulminant AIDS, they are still using, they have lost all hope. They are not motivated to take care of themselves. And in the process of that lack of motivation, they are sucking up resources from people in this community. They are poorly reimbursed Medicaid patients. They are poorly reimbursed Medicare patients. We've had patients in the hospital for weeks just waiting for a safe discharge plan, because if we discharge them and they come back within 30 days, worse off, the hospital loses money, the community loses money. I mean, I care for these people, but if we were talking about stuff that people can get behind, the bottom line is if we don't do everything we can affordably to prevent the spread of diseases like HIV, hepatitis C, syphilis, gonorrhea, chlamydia. These are diseases that are costly to treat, especially when they go on for a long time, and it's more likely to happen in people that use substance use. So if you guys want to pay that bill, you are welcome to.
Okay, anyone else from
Yes.
council?
Yes.
Counselor Ayla.
Thank you for the information. That was good information. Again, just looking at the data, there's 3,143 counties in the United States. There's 184 to 200 needle exchanges within the United States. So are we to assume that those other 2,980 counties have no effectiveness when it comes to fighting drug abuse?
Well,
and
we've been
to
populating
injectable
those
drugs?
counties.
But you're making the premise here, that without this, there's no answer. But there's answers in thousands of communities throughout the country. I don't know what those answers are because I'm not the expert. I mean,
Yeah.
you guys are the expert.
No,
But you're making the case that if this isn't available, if the needle exchange is not available, that this community is going to go to hell in a handbasket. And we're the only community in the country that's going to suffer these terrible things. And that what's our answer to that? Well, maybe our answer is looking at one of those 2,800 communities that don't have needle exchanges and effectively help people with addictions. Maybe there's an answer there that doesn't necessarily heap harm on the rest of the community while reducing harm on the addict.
That's a great point. Working in a community that didn't have syringe access, there were other options trying to pass out Narcan. I will say I dealt with a lot more overdose deaths there, and I dealt with it's kind of amazing how low the HIV rates are here. I was kind of surprised that I only have like a couple patients because the HIV rates were so very high. And I was in a town of 40,000. I can't speak to the exact numbers, but I would say there I had over 20 or 30 patients with HIV, whereas here I only have one. So from personal experience, I did see higher rates of HIV and Hep C, which are devastating diseases. And I can't speak for every physician, but I can speak for me that those take a hard toll. And I would say that's probably the case for most other physicians who treat those people. They had a lot of more programs available for patients with HIV and AIDS and a lot more funding and research and grants to help those people, which we don't have here. So yes, there are other options. Unfortunately, they look a lot like this. And our goal while I was there was to try to get a syringe exchange program in the community because of the research that we talked about today, because it is a better option than what we had. Now, granted, I'm only talking about one county versus another. However, the research does support that this has worked in many counties, and is a better option. We're not saying it's going to go to hell in a handbasket. For a lot of people in this room, it won't affect you, but that's because you don't care for these people. This will affect every day of my life. This will affect every patient I see. This will affect a lot of people, and it will affect your doctors, where we already have a shortage of physicians here, and it will affect your nurses and healthcare workers and those coming in. And I think that's the bigger concern.
Counselor Gomez,
I don't know.
anyone else? Counselor Latino.
I respect what you have to say, but this is a home of heroes, okay? There are a number of people all over that are doing the kinds of things that you've talked about here. Again, the only way we're going to eliminate this particular situation is to eliminate the needle exchange program in this town. Folks, again,
Order.
many of you have not been any other place. I have, okay? And the situation is, in the larger cities in the metropolitan area or in this state where I've worked, they're doing other kinds of things and they're not enabling. We're enabling. Okay. I don't have to get into where I've been and what I've done, but Jerry Murphy, whom I know is a Congressional Medal of Honor winner, and this is the home of heroes, not the home of addicts. Okay. This is a home of heroes, not the home of addicts. And we're going to get back to a point where there's respect for everyone, including children who are being poked with needles that are being left on campuses.
And with all due respect, sir, I've also been to many places, and I would love you to propose one of those options. But right now, what is being done is an ordinance to get rid of this without solutions being presented or alternatives. And that is our biggest concern, and that is the issue, is you're getting rid of something that is proven to be life-saving and not proposing alternatives, not giving us other options with data, with evidence. If, like we said in our speech, you give me an option that's better than a needle exchange program, I'm the one who has to treat the kids who get poked. I don't want that any more than you do. I want to have kids in this community. I'm still of childbearing age, you know? So this is very important to me. I just want a solution that we know works, and I don't want to get rid of something that works without something to help support in its place.
Alrighty. Well, thank you for this evening. And we are going to move next into executive session.
Madam Chair, I move to go into executive session for a conference with the city attorney for the purpose of receiving legal advice on specific legal questions under CRS section 24-6-402, parent 4, parent B. No adoption of any proposed policy, position, resolution, rule, regulation, or formal action shall occur at any executive session that is not open to the public.
Second.
You all good?
Yeah.
Need a
Second.
Second.
All for all those in favor?
All those in favor?
Aye.
Aye.
Okay. The time is 7:32 PM and we adjourn the meeting. We'll return in 10 minutes.
More things at the Hernandez family.